Our first speaker is going to be Dr. Pamela Kunz, who comes to us from Stanford University. She's on the oncology faculty at Stanford and has been at Stanford ever since she started medical school, internship, residency, fellowship, all at Stanford. A real Stanford person. She's also a terrific neuroendocrine oncologist and has lots of experience in treating neuroendocrine cancer. Her particular areas include gastrointestinal malignancies, neuroendocrine tumors, with a focus on clinical trial development and population science research in neuroendocrine and GI cancer. So welcome, Dr. Kunz.
Hi, good afternoon, everyone. It's a real pleasure to be here. So thank you to Ron and Ed, and I look forward to speaking with you throughout the afternoon. So I've been tasked with a very broad topic for about 30 minutes, and I'll try to even shorten it. But really, just a very basic overview of how to make the diagnosis, talking a little bit about who gets neuroendocrine tumors, and then some basics of how to treat them. I'll let Dr. Wolin talk more details about some of the clinical trials that are ongoing in this disease. I have some disclosures in terms of the types of research funding that I get. Okay, so my talk will really focus on three main areas. The first is who gets neuroendocrine tumors and why. And we'll talk about some of the ologies. So epidemiology, meaning patterns of disease, and then some of the biology. So what I just promoted you to be a physician, Ron, so Dr. Hollander. So in terms of thinking about, the biology and what we've really learned about the biology in the last couple of years, how to make the diagnosis, what symptoms do people get, looking at pathology, imaging, and blood tests, and then just some basics on standard treatments that we have available, and then Dr. Wolin will speak about upcoming ones. I like to start with this slide. I think it's actually very optimistic. So this is a slide of the number of publications in the scientific literature over the last few years and the number of clinical trials. So the publications are in yellow, the clinical trials are in red, and you can just see an explosion of research over the last few years. Everolimus and sunitinib were approved in 2010, and it's just really an exciting field to be in, particularly as a young researcher, and I really hope to impart that optimism to you. So we'll talk very briefly about the history. So in the early 1900s, the term carcinoid was coined. And it was by a German pathologist. And he noted 5 key features about this unique cancer: that they were small, had multiple foci, meaning multiple spots often. They were undifferentiated cellular formations, had well-defined borders. He felt they had no metastatic potential and noted that they were slow growing. Now, some of these we know are true, but we've learned so much over that 100 years. Carcinoid at the time meant cancer-like. In fact, over 100 years ago, they didn't even think that these were cancers. We now know indeed that they are. So in terms of the epidemiology or patterns of disease, this is a figure from one of Dr. Yao's publications a few years ago that did one of the first in detail looks at who gets these tumors. Is there a pointer on this? Is there somebody? I don't know. So if you look at the line in red represents the incidence of neuroendocrine tumors. Now, incidence, you can see on the bottom, is defined as the number of patients diagnosed per year. So since the 1970s up into the 2000s, you can see a really rapid rise in incidence. Some of that's thought to be we have better diagnostic tools, but some of that is also indeed thought to be truly an increased incidence. Thank you. Oh, great. Thanks, Ron. So, and then in blue, in comparison, those are incidence of all other solid tumors. So the scale is different. Certainly the incidence per 100,000 of other solid tumors is much higher. The incidence per 100,000 for neuroendocrine tumors ranges between 1 and 5 per 100,000, but the incidence is certainly increasing. The incidence by primary site, you can see, differs quite a bit. as we already know, and many of you know this, the incidence and the features by primary site are quite different. So some of these by color include pancreas, cecum, rectum, small intestine, colon. Lung is in blue, one of the more, the higher incidence primary sites. Now, you've all heard this, neuroendocrine tumors are rare, but are they really that rare? And what's interesting is that the prevalence is actually quite high. So the prevalence is the number of patients who are alive at a given time with that type of cancer. And so the prevalence of neuroendocrine tumors is actually higher than stomach and pancreatic cancer combined. So I would argue that they are actually not that rare. So you can see that neuroendocrine tumors are in orange in terms of the number of cases at any given time. Stomach has 65,000 cases, pancreas 32,000, esophageal and hepatobiliary are even lower. And I think that this was recognized a few years ago and has enabled researchers to do high-quality, large randomized trials in this disease because it is not as rare as it was once thought. So NET nomenclature. Are you tired of hearing like 500 different names for neuroendocrine tumors? So it's quite confusing. It continues to be, unfortunately, though there are some efforts at really trying to help improve the naming systems. So there are some clinical classifications: carcinoid versus pancreatic, poorly versus well-differentiated, functional, non-functional, or naming it by the hormone it's secreted, glucagonoma, insulinoma, VIPoma. Those are sort of falling out of favor. There is also an embryologic classification: foregut, midgut, hindgut. This refers to which tissue the organs originated from. So for example, some of the clinical trials, the eligibility is based on midgut neuroendocrine tumors, for example. The World Health Organization over the last 30 years has made an effort to try to help clarify some of this naming system. In the 80s, it was named by cell of origin. In the 2000s, they started saying, all right, well, we need to combine some of these features by grade and by their behavior. The most recent classification combines and calls, this is the sort of preferred terminology now, neuroendocrine neoplasm and by grade. And then also including for the higher grade tumors what the cells look like under the microscope. Are they small cell or are they large cell? So this is to try to simplify an otherwise complicated naming system. Lots of different organizations have put out guidelines. I've mentioned a couple of them. The European Neuroendocrine Tumor Society, the North American Neuroendocrine Tumor Society, the WHO, which I just mentioned. The American Joint Committee on Cancer has a staging system. So there is some common ground. And back in 2010, Dr. David Klimstra, who's an expert neuroendocrine pathologist at Memorial Sloan Kettering, he and a group of other neuroendocrine experts got together to really try to bring together some of these naming systems and classification systems and have made some basic recommendations for what features should be included in a pathology report. So for example, the terminology endocrine and neuroendocrine are encouraged. Carcinoid is an older term that we're not going to be able to get rid of, but is falling out of favor. In terms of the pathology, synaptophysin and chromogranin A are stains that should be done on most neuroendocrine specimens. The staging, these are the features that should be evaluated. And in terms of grade, mitotic count and/or Ki67 should be terms you see in your pathology reports, and a comment on grade. So I think that this is really helpful as we try to create standards for how pathology reports are created. So one just key, in addition, if you're seeking an expert neuroendocrine oncology or surgical oncology opinion, you should also request an expert pathology opinion. Okay, in terms of biology, we've seen some exciting advances in the recent years with neuroendocrine biology, but just some basics. So why is it called neuroendocrine? Well, neuro, because they can be stimulated by nerves, and endocrine, because they can secrete hormones. Not all do, but many do. About 80% of neuroendocrine tumors express somatostatin receptors on their cell surface. There are 5 types, and about 80% overexpressed somatostatin receptor 2, followed by type 1 and type 5. And octreotide has a very high affinity for somatostatin receptor type 2. We'll talk a little bit more about that later. And in terms of the molecular biology, this is that same study that Ron Hollander mentioned that was a CFCF-funded research project that really spurred a lot of exciting research into the molecular biology and underpinnings of pancreatic neuroendocrine tumors. Also, this is not for you to read the details, but to also say that research has also started looking into the molecular biology of small bowel neuroendocrine tumors. So you can see the dates, 2011 and 2013, very recent. We're just starting to get a sense of some of the underlying molecular biology of this disease. It's very exciting, and I think that it will for sure lead to areas that we can target treatments around some of that biology. Okay, so moving on, how to make the diagnosis. So these are, there's kind of 4 key clinical characteristics that I want to mention. One is that presenting symptoms are really variable. I think it makes the diagnosis quite hard. Certainly in general, and I'm not talking about the poorly differentiated neuroendocrine tumors, but slow growth is fairly characteristic of this disease relative to other cancers, hence the term carcinoid, as we talked about earlier. Some grow so slowly that treatment may not be needed, at least initially. Tumor cells can release hormones and peptides or proteins that cause symptoms. And these, if they can be measured in the blood, are sometimes called tumor markers because they are surrogates of what we think may be happening with the tumor. And then another key feature is that many neuroendocrine tumors are hypervascular. Well, what do I mean by that? So if you look at the panels on the left, these are typical colorectal cancer metastases. Just to orient you, these are pictures of CAT scans. They are like bread slices through the body with the patient laying on an examination table. This is their spine, and this is the liver. And these are dark spots in the liver, hypovascular. Now, in the panels on the right, these are neuroendocrine liver metastases. They're much brighter. They are very rich in a vascular supply, and actually some of our therapies are targeted at blocking blood vessel growth. You've heard of Avastin or bevacizumab. It's being studied in a lot of clinical trials. Sunitinib was an FDA-approved drug that also targets blood vessels. So we've been able to take our treatments and target the biology. Carcinoid syndrome, that's also a common clinical syndrome for patients. So a constellation of symptoms that results from production of polypeptides, biogenic amines, prostaglandins, other things that can cause symptoms of hormone excess that include flushing, diarrhea, asthma-like symptoms from bronchospasm, and sometimes valvular heart disease, which I'll talk about on the next slide. It's more common in patients who have small intestine neuroendocrine tumors than other sites. The treatment usually includes a somatostatin analog like octreotide. Carcinoid heart disease, I'll just mention this briefly. So this can happen in patients who have elevated serotonin, also as measured by elevated 5-HIAA. It can result in fibrous deposits on the heart and can cause heart failure and problems with the heart, and that needs to be part of the surveillance and management of patients with carcinoid syndrome. It can cause fatigue, abdominal and leg swelling. There are special diagnostics that are required, like getting an ultrasound of the heart to monitor for those fibrous deposits. And another key of my talk is multidisciplinary management. So I work a lot with cardiologists in managing these patients, and that's important. So net staging and grading. So what's the difference between those two? So the stage defines the extent of the disease. Is it localized or has it spread from the organ in which it started? And then more importantly, where is it and can it be removed? The grade is defined by the pathologic characteristics of the tumor cells. So that's when we need our pathologists to look at the cells under the microscope. And as I'd mentioned before, it's really important to have an expert pathologist because the pathology is quite confusing. So staging. I'm not going to spend a lot of time on this because we have a later speaker who will focus some on net imaging. But some of our imaging choices include CT scans, MRIs, octreotide scans, gallium PET scans. And a rule of thumb in general is that octreotide scans, generally speaking, are positive in low-grade tumors and negative in high-grade tumors. And the reverse is true for PET scans, generally negative in low-grade tumors and positive in high-grade tumors. And you'll see here, this is a picture of an octreotide scan. Staging, I'm not going to go over the details of this, but there is a relatively new staging system that includes neuroendocrine tumors. The AJCC staging, you've heard for other cancers like colon cancer, for example, there's stages 1 through 4. Up until 2010, neuroendocrine tumors were not included in that staging system. So fortunately now they are. And so there is a system for grading them, and that includes a description of the tumor, which generally includes both size and how deep it may go into the organ, whether or not lymph nodes are involved, that's the N, and then M is whether or not it's spread or whether it's metastatic. And similarly, so there's a small bowel neuroendocrine staging system, there's a pancreatic neuroendocrine tumor staging system. And then grading. So these are just pictures of some of the special stains that pathologists use of chromogranin A and synaptophysin. You'll also note chromogranin A can be a blood test also, but this is a special stain that's done on the pathology. The pathologist, in order to determine the grade, have to do tests of Ki-67 and mitotic rate, which are markers of how rapidly dividing the cells are. And then the blood tests, as I mentioned, these are the tumor markers sometimes of hormones that can cause symptoms. And then there are some other markers that aren't necessarily linked with syndromes, but can be helpful to monitor the tumor over time. And then finally, genetics. So genetics is a little bit different than the molecular biology of why we get these tumors. Some neuroendocrine tumors have a familial predisposition. It's a minority. Most are sporadic, meaning there's no family link. But about 15 to 20% are associated with an inherited syndrome, such as multiple endocrine neoplasia, von Hippel-Lindau disease, neurofibromatosis, and tuberous sclerosis complex. By far the most common are the MEN syndromes. Okay, and then finally I'll just touch briefly on some standard treatments. So this is probably by far one of the most complicated areas, and so I've tried to distill it. I think in my mind there are kind of 5 key things that weigh into who needs to get treated. And one is hormone status. So is it a functional tumor and secreting hormones that need to be controlled, or is it not? And then in terms of controlling tumor growth, what's the extent of disease? Is it localized or metastatic? What's the pace of growth? Is it stable or is it progressing? What's the grade? Low grade or high grade? Those are treated totally differently. And then what's the primary site? We're learning more and more that these sites behave very differently, have very different biology, and respond very differently to treatment. And actually, clinical trials now are separating pancreatic neuroendocrine tumors from other. Okay, so I'm going to give you sort of an algorithm for how we think about treating. So controlling hormones, this algorithm is fairly straightforward. So if patients have a functional neuroendocrine tumor that we think they have hormones that are contributing to symptoms of hormone excess, they need to be on a somatostatin analog. We now have 2 options. So octreotide, whether it's in the short-acting form or long-acting form, and now lanreotide, which is being used more commonly. So in terms of controlling tumor growth, that algorithm is a little bit more complicated. So if you're diagnosed with a neuroendocrine tumor, the first is, as I'd mentioned, one of those factors is extent of disease. Is breaking into, is it localized or has it spread? Is it metastatic? And we have a surgeon who will later talk about surgery. The mainstay of treatment and the best chance for cure is if it's localized and if surgery can be attempted. If it's metastatic or unresectable, and I will not go into the details, many patients with metastatic disease can also have surgery. That has to be determined on a case-by-case basis, and that will probably be addressed a little bit later. But for the most part, if patients have metastatic disease, we need to think about the pace of growth. Do they have asymptomatic and or stable disease, or do they have progressive disease? And then beyond that, if they have asymptomatic or stable disease, there are generally a couple of options. Observation sometimes is one. And another is that I think is evolving more is the earlier use of somatostatin analogs to slow the growth of disease. And then for progressive or symptomatic disease, there are systemic treatments, and then there are sometimes liver-directed treatments, depending on where the metastatic spots are. So again, another key, as I'd mentioned earlier, multidisciplinary team is really important. So you can imagine this is in this complicated algorithm. I'll go talk to my surgeon, my interventional radiologist, the endocrinologist. I mean, there's so many physicians that are often required in the management of patients. So to touch base on the systemic treatments, so again, grade. So systemic treatments for poorly differentiated neuroendocrine tumors are very different than for well-differentiated. Poorly differentiated neuroendocrine tumors are sort of rare among rare, and they, generally speaking, are treated with a combination of chemotherapies, cisplatin and etoposide. It's similar to a small cell lung cancer type regimen. Hopefully, and Ed may talk about this, there are some clinical trials in development specifically looking at this category of neuroendocrine tumors. And then for well-differentiated, the primary site matters. Is it pancreatic or is it non-pancreatic? And this is, as you can see, it gets more complex. But in terms of pancreatic NETs, we have more options. So somatostatin analogs can slow the growth of disease. Everolimus and sunitinib were recently FDA approved. They're both oral agents for slowing the growth of this disease. There are some oral chemotherapies, temozolomide and capecitabine, that can be used in many, many clinical trials that Ed will discuss. And for non-pancreatic neuroendocrine tumors, the mainstay are really somatostatin analogs. That's what the SSA stands for. There are other, so patients will, and I won't focus on this, but peptide receptor radionuclide therapy, though it's not available in the US, there is a clinical trial. Sometimes we'll use some of these other agents, though they're not formally approved in that setting. So just to share with you some recently published results. So these are examples of survival curves. This is how in the clinical research community we define success of certain agents. And so the PROMID trial was a trial that looked at octreotide versus placebo in patients with metastatic midgut tumors. And this is a survival curve that shows over time the probability that patients, how long they were before their tumors progressed. And in yellow is the octreotide, and in blue is the placebo. So the octreotide arm did better. They were alive longer without progression. And similarly for the clarinet study, which was a very recent study of lanreotide did the same thing, but we now know that it works in all neuroendocrine tumors. So somatostatin analogs certainly have both an effect on controlling hormones, but we know they also slow the tumor growth, and very well tolerated. These are the two agents that I mentioned that were recently FDA approved, everolimus and sunitinib. They are formally FDA approved in pancreatic neuroendocrine tumors, and they slow the growth in these diseases also. And you'll mention I'm specifically saying slow the growth. We don't see big shrinkages from either octreotide, lanreotide, or these two agents. But you can see that everolimus versus placebo slows the growth quite a bit compared to placebo, 11 months versus 4.6 months. And again, these are averages. And lastly, I'll mention that capecitabine and temozolomide, though this isn't a big randomized trial, this was a very small study done by Dr. John Strasberg at Moffitt of just 30 patients, but was very encouraging. These are really formally chemotherapies. However, they're oral and they're pretty well tolerated. Chemo, whenever I meet patients, no one likes meeting with their oncologist. Oncologist and chemo both get a bad rap, but capecitabine and temozolomide are actually pretty well tolerated. Best studied in pancreatic neuroendocrine tumors and are being studied in a couple of large national trials right now. So I will conclude just with a few key points. So the incidence of neuroendocrine tumors is increasing, and I think the prevalence is actually quite higher than was once previously appreciated. The clinical characteristics are quite variable, so it's really hard to compare one story to another. And I think, back to Ron's point, the treatment plan needs to be individualized for every patient. One size does not fit all in this disease. Guidelines on staging, grading, nomenclature, pathology, I think they're improving quite a bit, even just over 5 years ago. And the treatment must be tailored, as I mentioned, with those kind of 5 factors to keep in mind. And then really the most exciting thing, and thanks to organizations like CFCF, the net research is really just increasing exponentially, and I'm very optimistic about the future in terms of having more treatments. So I look forward to hearing questions from you at the end, so thanks.